We're on scene with a patient that's in his mid-50s. He's clutching his chest. He looks pale. He looks diaphoretic. This patient is just screaming cardiac. But at this point, we don't know if it's going to be a myocardial infarction or a pulmonary embolism or even an aortic aneurysm. And so we need to decide on which path we're going to go down very, very quickly. And it could be the difference between life and death for this patient. Welcome to episode 1 of Heart on the Line, a paramedic's guide to cardiac care, where we're going to break down these cases, the critical decision making that goes with them, and the red flags to watch out for. Every chest pain starts the same way, not with an ECG, not with medications, but with a first impression. And right now, this patient's body language is telling me a pretty good story. His skin is cool and diaphoretic. He's holding his chest with a tight grip. His breathing is labored, but it doesn't seem to be because of shortness of breath. It seems to be that he's in pain. This is already screaming cardiac to me. But at this point, I need to make sure that I'm not going to get sucked in too quickly and make a bad decision. Before I start going down any path, I need to rule out the ABCs. So in this particular case, does this patient have a good airway? Yes. Is this patient breathing okay? Well, right now it's present, but it's shallow. Circulation, he's got radial pulses. They're thready, but they're fast. This tells me he's perfusing, but something is stressing his cardiovascular system, either an occlusion or a systematic response to a bigger problem. Now that I've covered the ABCs, now I can start working on my differential. Now I'm thinking a myocardial infarction right off the bat here, but I don't have enough information to really narrow in on that. I need to start looking at other things like pulmonary embolisms, aortic aneurysms to make sure I'm not missing anything. And the first clue we're going to look for is by asking one very simple question. So this patient points straight to the center of his chest, describes it as a tight, crushing pain. He also says it's moving into his jaw. That's a classic cardiac pain pattern. If he had said sharp or stabbing, worse when I breathe, I'd be thinking more like pulmonary embolism or maybe even an aortic dissection. But asking that one question allows us to really start to narrow down and ask more questions to confirm our suspicion that this is a myocardial infarction. Now this patient looks like they're in shock. They're clammy, their blood pressure keeps dropping, they look like they're getting fatigued. These are all things that are big red flags to look out for as this patient starts to deteriorate. So now that my partner and I are thinking myocardial infarction, we start to go down this route of OPQ-STA and getting a sample to make sure that we're not missing anything. His answers confirm what I suspected. Sudden onset, nothing makes it better, crushing, radiating to the left arm. This is a myocardial infarction until proven otherwise. Now it's time for the final piece of the puzzle, a 12-lead ECG. This will confirm if this is a STEMI or maybe some other type of myocardial infarction or acute coronary syndrome. Sweet ST elevation in leads 2, 3, and AVF. That tells me that this is an inferior STEMI, meaning an artery in the lower part of the heart is blocked, most likely the right coronary artery. Now this changes everything because now I have to call a cath lab and get this patient prepared for a PCI. But in just a few minutes, we've gone from uncertainty to a clear diagnosis. A good chest pain assessment isn't just about following the script, it's about knowing what questions to ask, recognizing the red flags, and making decisions that give this patient the best chance at survival. In the next episode, we're going to go inside the body and go to the cellular level to show you what happens inside the heart during a myocardial infarction and explain why treatment is so crucial and time is everything.